All right. Hello, Sameer. How are you?
Hey, how are you?
Awesome. I am so glad to have you here today. Hope you're having a good morning.
Yes, absolutely. Thanks for having me.
With that smile on your face, it looks like you had a good morning. It's great to have a good friend and a colleague here with me today. For introductions, we'll go directly into the material. We have about a half an hour today. Logistically, folks who are listening, please feel free to put your comments in wherever you are watching this. There's a few different channels that we're streaming this on, so wherever you are, just put your comments in your platform. It should show up for us if you have any questions. With that, I am going to go directly into introductions. I'm your host today. My name is Ahmed Zaidi. I'm the CEO and Chief Automation Officer here at Accelirate. We are a automation and AI focused services firm that does a lot of work around process automation in various industries, healthcare being one of them. I have the pleasure of having Sameer Sethi, Chief Data and Analytics Officer at HMH. Sameer, it'd be great if you could tell our audience a little bit about HMH for those who are not in Jersey and haven't seen one of your hospitals just driving down the street. It would be great to give a sense of size and scale of your operation and your role there as well.
Absolutely. And thanks folks for joining. The Accelerate team, thank you for having us. You guys are an integral part of our team. I really appreciate everything you guys do for here and deliver impact. Uh, HMH, Hackensack Meridian Health, is a regional health system based out of New Jersey. We primarily span all the way from north to south of New Jersey, and we have around 18-ish hospitals, depending on what you call a hospital in the setting. um, Almost 38,000 employees, that are clinicians and obviously back office support, leadership, and also function in various other aspects of what it takes to run a health system. I function as the data and analytics officer for the organization. I also have a few of the portfolios under my belt. One being RPA, robotics process automation. The other is an extension of, at least what I call an extension of descriptive analytics, of how we thought about data and analytics in the past, so which is AI today, and now extending further into generative AI. And the third piece is software development. We as a health system have realized over time that it is not sufficient to just have the data and the data available, but means and ways by which we deliver the insights, and we do that with software. So I have a team of folks that actually build software, not as extensively as a product team would or product organization would, but we do tend to take our insights directly into workflow, and that requires not only re-engineering their processes using RPA and other functions, but also build software that embeds these insights into their existing workflow. So primarily 3 to 4 buckets of work. Traditional data and analytics, uh, predictive data and analytics, RPA, and then software engineering.
Perfect. With 18 hospitals, and I've seen the size of those hospitals from Hackensack Hospital over in Hackensack to JFK Medical Center here, and many others that you have. I assume we're talking millions of patients.
Absolutely, yes. A lot of
So,
patience.
so if it's a 1 in a million issue, it happens a few times for him. That's interesting. And one of the small anecdote I wanted to give everyone here. About 6 months ago, when generative AI was just coming out and it was all the buzz and still is, I saw a post of Sameer, or somebody else had posted a video of Sameer talking about what seemed like generative AI, right? It was interesting, and I reposted that and then texted Samir. I was like, dude, that's really cool. I mean, this thing just came out, and you've started working on it already. He goes, no, that's from about a year and a half, 2 years ago. He's been working on some interesting AI use cases, and one of the interesting things that he mentioned there, which I think is valuable to a lot of folks who are working on solving problems. He said it's not about the underlying technology. Don't start with the underlying technology. I need to solve a problem with AI. Let's start with the problem that you're trying to solve, and then apply whatever the best technology is to solve that problem. I think I'm rephrasing that correctly, Sameer. So he's been doing this stuff interestingly for quite a while. Let's start with what are the AI use cases, and again, it's interesting to talk about traditional AI. I guess I'm calling it legacy AI now, the usual models and predictions. But you've been doing that stuff for a while. Let's talk a little bit about what you've been doing in that space. What are the use cases? What are the problems you're trying to solve in the hospital setting?
Yeah, absolutely. So yeah, and I took the liberty of selecting a few slides that we have used to explain this problem and the solutions that we have. So I'll share that in a bit. But I wanted to, start off by just double clicking into what Ahmed just described. So I truly believe, and we've been trying to explain this to leadership, not in context of the fact that we've been doing this for a while, but how things have changed. So for us, uh, AI or generative AI is not absolutely not new. What has changed, and maybe perhaps clarification around that is more important. Is how do we do AI, right? So what wasn't available to folks as such me and organizations as such HMH is the availability of the vast availability of large language models, right? We were putting models together, right? And we have been doing this for quite some time, and I've done this across multiple organizations. But what was never available for us was trained models that have been extensively trained on publicly available data or otherwise, right? And that's what changed in the last 1 year, right?
Yep.
So AI in my mind has become uh, it has become dangerous, and perhaps maybe we'll talk about that a bit. But what has become is AI has become easy because we can now go to Google, for example, that being our partner at HMH, and we can ask for access to MedPalm or Bard, right, which has been trained on millions of documents. That wasn't available to us. So that's when I say AI has become easier for us, where we can get access to it. Obviously, and have a slide that talks about how we think about using large language models, but access to that has become easy, and thus our solutioning has become a lot faster. I'll touch slightly on the dangers of this. These, in my opinion, most of the large language models in the market today do not have the right level of governance. So these models hallucinate, and us in healthcare setting, we have to be really careful about how we deploy the use of these models, because we handle patients, and we handle lives, and we handle lives that are in pain and have disease, right? And it's important that we don't give people tools and capabilities that haven't been tried and tested. And these models have not been tried and tested for the most part. They've been signs of people have unfortunately committed suicide as a result of listening to the model,
Yep.
right? So I think what needs to happen is these that the proper governance has to be put in place. That's number one. And then I think we, as I spoke at Google a few weeks ago, and what I told them was, this feels like 1995, when the internet became mainstream and no one knew how to use it.
Yep.
That's where we are today with AI, right?
Absolutely.
Or generative, should I say? It's just people don't know how to use it, and we don't know how to deliver it, and it's going to take some time to sell that.
That's awesome. So let's get into a couple of use cases. And I actually took a few notes here while I was looking down to ask you a couple of follow-up questions. You brought up interesting governance and concerns around Gen AI. So let's go through the use cases, and I'll have a couple of follow-ups.
All right, and you guys will keep me on a time check right here, so I
Absolutely,
tend
you're
to talk.
good.
As you guys can tell, I can talk quite a bit, and so I'll go through these use cases. This again is more so how we've been thinking about the AI issue. So I'll talk about these use cases. Please stop me where you think there's more than enough here, and then we move
Couple of
on to the
use
next.
cases would be great. That'd be
Yeah.
awesome. Look forward to it.
So three areas, if you think about AI in general, right? We tend to divide our use cases into into use cases that drive efficiency. And within efficiency, there's clinical efficiency and there's operational non-clinical efficiency, right? So think of efficiency as us from a clinical perspective of us allowing or providing some capability by which we can summarize notes, which are lines and lines and lines of notes in a patient record, and provide a summary to a patient or to a provider saying, before you go speak to this patient, and all of us have experienced this, the physician isn't reading the notes while talking to you, instead
Yeah.
already has a summary instead of spending 20 minutes doing it. We provide efficiency by which we summarize the information. That's one piece of this. The other is clinical decision support, right? Which is where we're saying to a clinician that we will not be the doctor, AI will not be the doctor, but we will give you something to help take a decision for the patient, right? That's the second bucket. And the third is patient experience. So what you'll see here is more so use cases that are related more to the one and two, which is efficiency and clinical decision support, not as much on patient experience, because I don't think, as I mentioned, AI is there yet, right? So this use
Yep.
case that you have in front here is something which has to do with us being able to predict serious illness, and unfortunately, this is the part of healthcare which we as we don't tend to talk about. Patients get sick, and physicians get very passionate about fixing the problem. Unfortunately, what we don't realize is that, or even physicians at times don't realize in time, is that there isn't a way to fix a problem, right? And this is where this capability comes in, where we provide signals to a physician saying that it's now time to talk to this patient and their family about moving this patient into palliative care, right? And that's the kind of care that's beyond medicine, gets into more of the comfort care now, and then unfortunately eventually going into end of life. This is very near and dear to me. I lost my mother-in-law 2.5 years ago, and what we found out about palliative care, or at least her needing palliative care, just a month prior to her passing away. So this was something which I thought, not only did I experience it at a personal level, but being in healthcare for 15 years, I felt that was much necessary. So this is AI capability, the capability that that scores patient, and scores all patients at HMH, right? That we have patient record for, and at the time of interact the physician interacting with the patient, gives them a score of of this person going into palliative care, right, or hospice. And as a result of this, within the workflow, what you see on the screen is this is what we call as a BPA, or an alert that shows up in our EMR. EMR is our CRM for health for doctors,
Of
and
course.
this pops up, and what this does is it alerts them to say this is where the patient is, the chances of this patient going to palliative care, and if you accept, it actually puts an order in for the palliative care team to come and evaluate the patient, have the conversation with the family. As a result of this, and this is the second screen here, right, of what happens here is what you see on the top, and there's a lot of words here, but what's important to look at is, if without this capability, the 69-year-old male would have had 3 hospital admits, 1 rehab admit, 1 ICU day, 13 hospital day, and then patient dies in the hospital. Now, if you switch your eyes to the bottom of the screen, with this capability, that reduces to 1 admit, 3 hospital days, 64 days in hospice, and death at home, which is, in my opinion, much preferred, right? So going back to my personal example of my mother-in-law, this is what we would have much preferred. Unfortunately, this AI capability wasn't available, right? And does her span, or within her span within hospice care or palliative care, was a lot less. So that's what this AI capability does. This is an example of decision support where we are providing clinicians using AI. We are telling a physician that it's time to talk about palliative care. It's time for the provider and the family to consider this facility available to them.
Makes sense. No, this is interesting. Samir, talk a little bit about, and I'm sure you have another use case, but I wanted to ask you, what was the validation like? How did what was how did the physicians themselves view this? how did you validate what the AI results were? Again, we talk about it's not a binary, yes no type thing. There's a percentage, and what is the data that you use to train this stuff? How did you get here? Is really what I'm asking, I guess. And
Yes,
how did you validate those?
yeah, us as a health system are fortunate. We are fortunate to be data rich, right? We have patient data. So the training, obviously, as we built the model, the training data is available to us. Validation is an interesting area where I think again we have we're fortunate enough to actually not even just have the patients, but also the providers that can help. So the validation process is obviously we go through a pilot, a micro pilot, and we go through a pilot, and then eventually go into production. Such use cases require a tremendous vigor around validation, Emma, to your point. And we have the facilities available. So what we generally do is obviously first we test these capabilities on data. So think of the concept of having a digital twin. We don't formally have that, but I like to think that we do, right? So we create the concept of digital twins, in our ecosystem, and test our hypotheses of what comes out of these models against that. We then take this into a smaller group, smaller patient population, right, and test it, and to see how this is working, just not from an output perspective, but also from a workflow perspective. Is it working for the physician? Are we providing these insights at the right time, at the right place? And then finally, once we think that it's validated and we think this is a sound number, and that this model is giving out, that's when we take it into production. In addition to that, we have other mechanisms. So there's something called the IRB, which is a research mechanism by which we validate what is happening here, and we have researchers looking at this because they are more that they're more experienced with what it takes to take things in production and de-risking the capabilities that are built. So various mechanisms, depends on what the need is. What I can tell you is that it's a slow process, unfortunately, right? This is what slows at least technologists like us down, right? But we appreciate it and we see why it is absolutely necessary.
No, I think given, we used to think, I used to be back in on Wall Street, and we used to think doing a bad trade was catastrophic. But this is extremely more important. You're looking at people's lives, and there's a lot of emotion involved. So, and again, being able to look, I've had folks within my family go through exactly scenario number one that you set up there: three hospital admits, go back to the ER, go back home, go back to the ER, go in the ICU, and eventually end of life. But yes, the bottom one would have been perfect scenario. It's interesting. Talk a little bit about your data strategy. You're also chief data and analytics officer, and data and AI go together because you need one to feed into the other. Talk a little bit about that, and what's your, how do you get all this data? Because everybody is always worried about, I have so many sources, I don't have, all the other stuff that goes along in capturing data. There you go, you have a slide for it. Awesome, let's talk about
Yeah,
that.
and just a part of my background, I spend a little bit of time at McKinsey, so I tend to think and speak in slides. So yes, I do have slides for.
No,
Uh,
that's awesome. Let's talk
yeah,
about that.
so yeah, so here's uh you know I've done this. I've done this wrong a few times, right? I'll admit, as in my capacity, at various different levels. I worked at, I tend to draw my career or line in my career in 2006, seven, which is when, I got married to an occupational therapist, and, she convinced me that I should do things beyond work. So I got into healthcare. I was at Deloitte back then, and then I started working with Mount Sinai. I learned quite a bit there. Then went to McKinsey. Then went to Bon Secours Mercy Health, and then I'm here now. So I've done this incorrectly, should I say, a few times. And and when I say that, what I want to bring to surface is the passion of not just providing the right maturity of data, but also the speed at which it's delivered. Unfortunately, that those two concepts don't quite mix. It takes time to mature data. So what you see on the screen is how we think about, data coming in, and the curation of that. And what we say to our folks is, if you need something tomorrow, we will give it to you at a bronze standard. If you need something next week, we will give it to you at a silver standard. If you need something in a few weeks, we'll give it to your in a gold standard. And if something that you need all the time, then we'll make it available in the curated data mart sort of setup. So what we have, our strategy around data is that we will make different maturity levels of data available, starting from what is available tomorrow, and you have to build the right leniencies in your usability of that data, right? And over time, we will give you something that is very curated and is 100% accurate. And what there's been a lot of education in the at HMH around this, where where we're saying is what we're saying is that it's going to take us time, but you figure this out as to how to use this data, but we'll make it available for you ASAP, in minutes, days, and then months over time. And if you give us more time, the data is going to get cleaner and better for your specific use. And this has worked really well for us. This is at times, at least from a technical perspective, is what's called Delta Lake construct. Delta Lake is a capability that's available in the market today. We don't use Delta Lake. We're a Google shop. But what we have done is we've taken that inspiration and aspiration from there to make different maturities of data available to us, and it's worked really well. We have assets that sit not more so on the bronze, but mostly on the silver and gold and the curated data marts. But I think providing these different flavors of data at different maturity levels with different accuracy is has helped quite a bit. We have actually extended this further to actually even have our assets actually have a color against each of them, which changes over time. So you'll see and I'm just going to use this example, certain of our assets in the beginning of the month, show an orange, then and as you go into the middle of the month, it turns to yellow, and then eventually turns to green. And what we are educating the organization on is how that the reliability of that insights coming from those assets have matured, because the underlying data has matured.
That's awesome. Um, Lift a little bit back to what you were talking about. I know that the continuum of care was a, what you may call a data fed, not large language model. Talk a little bit about what you're doing with Gen AI, and if you can also then touch upon both, all your AI initiatives. What are the challenges? How is it received? Um, what are the normal objections? And from your perspective, you're dealing with people's lives and sick patients, which is really um, you know has a lot of potential of things going wrong. How do you mitigate those? What have been the objections, and how have you been able to overcome those?
Yeah, so another slide for that, right? So the way we have thought about Gen AI and AI capabilities is we've, in addition to thinking about priority and ROI, we've also had to now, because Gen AI is coming at us so quickly, also think of this from a risk versus impact perspective, right? So risk was obviously something that was there, but it wasn't really like the top of the mind conversation, right? Because large language models and the use of large language models has accelerated, by which not only by which we can deliver as I described, but also by which we are expected to deliver. We have had to put this together. So this is a live, crime scene, live crime scene today, where we are continuously looking at use cases that are related to care navigation, as I described, which is more patient facing, to admin and ops, which I described on efficiency, to care delivery, which is more decision support, right? And we're plotting this into this 4x4, right? And what that tells us is which are risky bets, and which are or should I say, which are more riskier than others, and which deliver more impact than others. And this has helped us decide which ones do we work on first, right? So a lot of emphasis going on today on the concept of risk, right? If we do this, what are the risks involved? And as a result of this exercise, we've been able to surface lots of good use cases, both on the risky bet side, but laying those expectations up in the just in the beginning to say that, hey, we're going to do this, but there's a risk involved here, and tell us that it really makes sense for you to do it. Otherwise, we will not. And then the other side of where, what are more, what are more impactful, which which impact the bottom line. So for example, I'll talk about the ones, naturally all the way on the top right, which is CDI, clinical documentation, right? This is a use case where we're using AI to make sure our documentation is accurate. And when we in healthcare, when we talk about documentation, it is not just about just writing the information in, it's also coding the information in. And what does coding do? Coding gets us, one, more money, right? What that means is that if we don't code, we don't get paid. The way we send a bill to an insurance company is what's called, it's an EDI, and it's called 837. How we get back is an 835, and behind that, all that is code. And if we don't code appropriately, we don't get paid. In addition to that, if doctors don't code appropriately and just leave data in unstructured way in a clinical note, we also don't get to do follow-up care, right? So for example, if a doctor were to go in the clinical note and say that, and type in that this patient has issues related to malnutrition, right, it's just going to stay in the notes, right? But if
Makes
this
sense.
doctor went and coded it, we can do something about it, so it becomes more actionable. So AI here actually helps, with the clinical documentation, where it prompts a provider or a clinician to code appropriately. It prompts our billing team to make sure that things are coded so we get paid for it. And that's where, we felt that was a priority win for us. Low risk, high impact, right? And then I'll go all the way to provider advisory, right, which is here, which is something which we haven't done for the most part, right? From a perspective of Gen AI. Now, AI, as I described, we have, right? But from a Gen AI perspective of generating recommendations using clinical data, we have not done yet. We have gone as far as summarizing that data. So we have gone, if you look at right here, which is clinical note summarization, we have done that. But we're not ready to actually provide provider advisory using Gen AI large language models.
Got it.
Now,
Well, that's
how do we think about, just real quick, how do we think about
no. Go ahead, please.
using of these, yeah, capabilities? This is how we think about use of large language models. So just going back to the early part of our conversation, there are lots of large language models available, right? Some are great, some are not so great, right? And we are I should say evaluating, but we intend to use a good portion of them. But what we want to what we want to be very clear about is that we will not use them as is. So what we are doing is we are bringing the large language models from these vendors, and thank God they have them, right? We did not have them before,
Absolutely.
right? Then we bring it into what we call is the POMS, which is a private optimized model garden, right? And what we do is that we fine tune this model using our private data sets, right? And the fine tuning is not just related to how it responds, but how it thinks, right? And that's where we start to play with the weights of these large language models, which actually starts to at times creates what I call it a small language model for us, right? And that is what is we put our use cases on top of it. So whether it be patient support or clinical care or research support or operational support, we are putting these use cases not on the large language models that are publicly available instead. And we strongly feel that that's irresponsible. But instead we bring the large language models, train it with the private data sets, optimize it to our needs, and then eventually have use cases point to these optimized models versus the large language models.
That is actually really interesting, and I think very insightful for folks who are thinking about using these things. That is great. I think we're probably going to have another session just on Gen AI and how you're using this. This slide itself, I think we could talk about for a half an hour, just talking about use cases and all of that. We'll take just a couple more minutes in the towards the end, shifting to some of the things that that might not in retrospect talking about all this AI stuff might not look as sexy, but are very impactful, right? Process automation, you said, was also in your purview. If you could just take a couple of minutes about how you're using process automation, embedding some of the AI capabilities into process automation, where that started, where that's going, and the kind of impact that's having in your organization, I think that would be really awesome as well.
Yeah, absolutely. So, when we think about, RPA, right? We, at least I took a position when I joined HMH last year that we will not call it RPA, right? We're going to call it IPA. IPA is
Awesome.
intelligent process automation. And what we have done is, again, just having the luxury of being, HMH putting some faith and trust into, into me and my team. We embedded AI and RPA together, right? So as you guys know, RPA, and again, there'll be folks on this call that may call it differently, is emulating a person or what a person does. And I think AI, in my mind, is emulating how a person thinks, or the cognitive function, right, associated to human minds. And what we have done is we have brought that together. So what we aspire to deliver, is RPA capability that is beyond just, a rule based approach, but starts to look at things that are, and question, puts in the factors of the if then, right? And
Yep.
and I want to be very careful when I say this. I want to make sure that I'm not selling vaporware here. These are early days for us, right? We still have already so much RPA use cases that if we venture down that path, we wouldn't surface in the next we wouldn't surface out in the next 3 years. So there is definitely just standard traditional RPA work that's happening here, right? But what we are now thinking about is, because we have had quite a bit of maturity with how we deliver AI and data, and the data maturity and what's available, we are now embedding AI into RPA, and then thus calling IPA. from a
That's
from
awesome.
from the perspective of what the team has done, we have shifted from what I see, to the what you all see from the chart on the left to the right. And I think this makes more sense for folks that are at HMH. But what I would point to you is the difference in how the colors have spread, right? What that means is that we started off in a very heavy finance cash reconciliation space, and our focus has been trying to diversify. So the way we think about impact today is, yes, it is about ROI, but it's also about diversification. So we almost, we have two check in the boxes, and one of them has to be checked when we think about RPA use cases. One is does it deliver impact, and what is the dollar ROI there? Yes, super important. But then we also think about diversification, and sometimes ROI doesn't support it, and that's okay. So our intention is to mainstream RPA or IPA across the health system, and we're doing this in challenging or not looking at the ROI there. But it's
That's
been it's
awesome.
been very successful. If you look, I mean, we have 90 automations live today. We have built many more. A lot of them have been removed from production because the applications that these are embedded in have come up with native capabilities, and we're okay with that. But so far, 19 automations we have spanned across 6 domains at HMH. We've saved around 69,000 hours. That's almost 33 FTEs for us, right? And these FTEs obviously are still here, but they're focusing on more meaningful tasks versus mundane tasks, right? Which have been automated here. We're working on 27 automations. We're adding one more domain, and that should give us around 14,000 more hours of savings.
That's awesome. That's awesome. Anything in specific that stands out in terms of raving success?
Yeah, I'll use two examples. One being that big blue there, right? So cash reconciliation has been really big for us. We no longer do bank reconciliations using people. Instead, RPA bots do it for us. So that's one piece. On the other side is we are using RPA for two aspects, and I'll go back to the buckets that I described in the beginning of the conversation. One is from an efficiency perspective. We are using RPA to populate our A1C results, right? So when we get lab results back from labs that are not native to us, So they come in the form of PDF. We use RPA to actually populate that data or the results of what's in the labs into our EMR, which is our CRM. Right, that's one piece of this. From a patient education piece, we are using RPA to deliver information to to patients prior to them going into care or procedure, right? So we educate them using RPA, where we use RPA to bring information from various different systems of record that have this data, and then present it in sort of one experience for the patient.
Perfect. So I'm a regular at the JFK hospital down the street. So when I go in for something and an email comes in to tell me not to eat anything the night before, that's probably about sending it to me, which is awesome. Thank you, Sameer. I think we're at time. I really appreciate it. We look forward to working with you. I'm going to see if there's a so some of the comments are appreciating you. I really appreciate you coming in today. We will definitely be able to answer any of your questions. Send it in to us. We will forward it to Sameer. I think we will be following it on all the channels. Thank you very much, Sameer. I really appreciate your time today.
Yeah, likewise. Thank you so much for having me. And folks, please, if Ahmed has my information, if you all have specific questions as to how HMH is approaching this, and or how, in general, I can be helpful, happy to help.
Thank you very much. Have a great day.
Bye bye.
Bye bye.